So good evening, everyone. I'm so excited about tonight's turnout. Welcome to our Disparities in Black Maternal Child Health event. Welcome to the Star Health Sciences Complex. If you've never been here before, we're so excited about this evening's event. My name is Dr. Regina Wright. I'm a professor here in the School of Nursing, as well as the Associate Dean for Diversity, Equity, and Inclusion here in the College of Health Sciences. So our event tonight is aligned with Black Maternal Health Week, which ran from April 11th through the 17th, so it just ended on yesterday. Black Maternal Health Week is a national week of awareness, activism, and community building intended to deepen the national conversation about Black maternal health in the United States, amplify community-driven policy, research, and care solutions, center the voices of Black mamas, women, families, and stakeholders, and provide a national platform for Black-led entities and efforts on maternal health, birth, and reproductive justice. Lastly, the week is intended to enhance community organizing on Black maternal health. So we're so happy to have you all here to hear from folks working in clinical practice around these issues, as well as in nonprofits and working on policy. So I want to talk a little bit about the statistics. And I pulled this passage from an article in Delaware Today last year that really talks about the crisis. According to the Centers for Disease Control and Prevention, the overall maternal mortality rate in 2021 was 24.6 deaths per 100,000 live births. Black women are 3 times as likely to die from pregnancy-related causes as white women, with a maternal mortality rate of 43.5 deaths per 100,000 live births. In addition, there's a significant shortage of maternity care providers, whether it's OBGYNs, midwives, or doulas, relative to births, as well as a drastic lack of postpartum support services available to new mothers. So if those shortages exist for everyone, you can imagine what the shortages are in the Black community. In Delaware, racial health disparities continue to be an area of concern for women and their maternity care providers. The Black maternal mortality rate in the state is 36.3% compared to 14.8% of Caucasian women, according to America's Health Rankings. Similar racial disparities exist among infant mortality rates. The March of Dimes reports that the Black infant mortality rate in Delaware is 12.4 per 1,000 live births, compared to 3.1 per 1,000 live births for white babies and 5.6 per 1,000 for Hispanics. So wow, there's a big disparity that needs to be fixed. Tonight, we have convened a physician keynote speaker and a panel of health, policy, and nonprofit experts to discuss the state of Black maternal child health and health disparities, as well as prevention and intervention. Now, I'd like to share a special welcome from Lieutenant Governor and UD nursing professor, Bethany Hall Long.
Hello all, Lieutenant Governor Bethany Hall Long, joining you virtually today. I am so sorry that I'm not able to be with you in person, but I am so grateful to the UD College of Health Sciences and the Zeta Phi Beta for allowing me to send a message to accompany today's discussion as we commemorate Black Maternal Health Week. The collaboration of health and policy and nonprofits experts on today's panel, as well as the discussions being had, are really critical in the process of ensuring that Black mothers have access to equitable health care. I am sure many of us, and our advocates especially, you know the statistics, but they bear repeating. In Delaware, the Black mortality rate is 36%, which is more than twice as high for Hispanic and white mothers. And what makes this statistic even more tragic is that more than 80% of pregnancy-related deaths are preventable. So as Lieutenant Governor, I want Delaware to be the best place to live, work, and raise a family. And in order for that dream to come to fruition, we must address these inequities and ensure that proper preventative and intervention measures are taken for Black mothers and newborns. That means supporting a healthcare system where doctors and nurse practitioners and providers look like their patients, and patients are not turned away for care or discounted. The experiences of Black women matter, period, full stop. We have to listen, really listen, and ensure they have access to a suite of services for women and children so they can thrive. There's clearly much work to do, but with awareness and events such as this one, we can collaborate, we can connect, we will move the needle in the first state. And I truly look forward to working with each and every one of you on these endeavors. And let's celebrate Black Maternal Health Week.
Thank you, Bethany. Now I'd like to introduce Ms. Aisha Monroe, who will introduce our keynote speaker.
I'm wearing many hats today. She's introducing you. All righty. So our keynote speaker is founder and CEO of Piedmont Preferred Women's Healthcare. She is and has opened a practice in 2007 and now operates in Virginia and North Carolina. She is an attending physician at UNC Rockingham Hospital and serves on the committee of American College of Obstetrics and Gynecology and Government Affairs. She earned her undergraduate medical degree, at Yale University. She completed her master's in public health with a concentration in maternal child health from Harvard University. She completed her residency at the University of Pittsburgh Medical Center and has dedicated her professional career to serve in the improvement of women's health and equity. And we will now have our keynote speaker.
Thank you for having me. Thank you so much for the invitation. A special shout out to Aranda Osborne for connecting me with Vicky, and also just thank you, University of Delaware, and for the Sisters of Zeta Phi Beta for inviting me. So let's talk about the disparities in Black maternal and child health. In addition to starting Piedmont Preferred Women's Healthcare, which is my private practice, I started Rise Women's Institute to deal with some of the, I guess you would say some of my extracurricular activities around trying to decrease maternal morbidity and mortality. That's just my contact information. The mission statement for Arise is to decrease maternal morbidity and mortality and to equip women with the skills to advocate for themselves, their families, and their communities. Well, okay, there we go. And that's some of my background, which we already discussed. And let's just looking at the problem. The US spends the most on any industrialized country on healthcare. However, we have some of the worst outcomes. It's well known by now that it is dangerous to actually deliver in America. And there's a lot of reasons that go into that. It's hard to compare our country to any other country because of, I think, primarily the roots of slavery that we still see the effects of today. And then outside of that, there are just a lot of other contributing factors, such as the fact that when we try to compare ourselves to European countries, many European countries and Asian countries have universal health care. So that means that everyone gets health care. It's just a standard, and we don't have that. So maternal mortality in the US is 23.8 per 100,000 live births. For African Americans, it's 55.3 per 100,000 live births. Mortality, which means death, is the worst outcome, but morbidity or near-death events occur perhaps 70 to 100 times more. Those statistics, it shouldn't surprise you, are just hard to come by as far as how many near-death experiences actually happen. We don't always report them as a medical institution, and so a lot of times it's just it's some things that you can garner from the medical chart, like blood transfusions or needing to ship a woman from a level 1 facility to a level 3 facility, or vice versa. Addressing maternal deaths and poor outcomes requires working across many sectors and using different modalities to bring about the changes necessary. Each mother saved is a family saved, honestly. So I want to just look at some of the, some of the people that have highlighted what some of our issues are. We know this young lady, beautiful young lady, Serena Williams. She had a pre-existing condition, had a blood clotting disorder that made her, from the jump, a high-risk pregnancy. She required an emergency cesarean section due to fetal distress. After delivery, she said she lost feeling in her legs and she felt herself dying. She developed a large blood clot in her lungs and she had difficulty breathing. She spoke to the nurses several times about what she was feeling, and she was told to go back to her room and lie down. Eventually, she was able to get her doctor to take care of, to understand that she was decompensating. Excessive coughing ended up ripping open her C-section wound. All in all, she required 3 more surgeries to evacuate a hematoma, which is just a large blood clot, repair the C-section, and also to place a filter in her leg to further decrease blood clots in the lungs. These surgeries, complications, are part of the large scope of poor outcomes that can limit a woman's long-term productivity. And just to highlight that, she ended up retiring at 41 because she did want to have another child. She did have another child, a healthy baby. But look at some of the other women who ended up working a lot longer because they didn't have some of the reproductive outcomes that she did. So Navratilova played tennis until she was 49, and Billie Jean King played tennis until she was 47. This is Kira Johnson with her husband, Charles Johnson. His quote is, "There's no doubt in my mind that Kira would be here today if she were a white woman." This is maternal mortality, which is a maternal death. Kira went in for a routine repeat cesarean section in April of 2016. The surgery took 17 minutes. The husband alleges that this speed was part of the negligence. Less than 2 hours after surgery, her husband, Charles, saw blood in her catheter bag. The catheter bag is where we're supposed to collect urine. So seeing bright red blood in the catheter bag should have alerted everyone that there was a problem. An emergency CAT scan was ordered, but it was not done. It took hours to take her back to the OR, but it was too late. And you should know that she died at Cedars-Sinai, which is one of the preeminent hospitals in America. It is where the rich and famous, the Kim Kardashians, etc., go to deliver. Kira died from massive internal bleeding, a postpartum hemorrhage, at one of the best hospitals in America. This lady, Crystal Anderson, and what I guess is also unfortunate is that at any given time, if I'm asked to give this talk, I can usually find a Black woman who has died relatively recently to highlight what these issues are. And that truly needs to stop. This young lady was 40 years old. She died from sepsis a day after delivering a 20-week stillbirth. She'd had a prior stillbirth in 2022. Her husband grieves her loss, of course, because again, it felt very unnecessary. You should know that 80% of maternal deaths are preventable, and that's from the CDC. That's not, a parent saying, I wish my daughter was here, or a husband saying, this is completely preventable. This is the CDC stating that 80% of maternal deaths are preventable. He described, and I'm quoting him, expecting somebody who's had a loss to go 4 weeks in between seeing their care providers. That's the same protocol that's done for a 23-year-old that's very healthy. He said, it can't be a one-size-fits-all process in medicine. And he is certainly correct in that. So his biggest complaint, and I would agree with him, is that they had this fetal loss, a stillbirth in 2022. I do not know what the workup was, but anytime we have a loss like that, there should have been an extensive workup to see if there was something preventable that we could have done to treat her for the next pregnancy. Yet for the next pregnancy in 2024, by his report and by the records for her prenatal care, they treated her as though she was a routine pregnancy, not someone that would need additional care because she'd had the prior stillbirth. She had another stillbirth. This one perhaps was in her system longer. It ended up forming an infection, and she died of sepsis, which is an overwhelming infection that causes basically many organs to collapse and fail. This young lady, Tori Bowie, was once the fastest woman in the world, and she died last year. She died in childbirth at home. It's unclear if she received any prenatal care during her pregnancy. Friends and loved ones say that she was 8 months pregnant. When she died, she was 5'9" and 96 pounds. The baby weighed 1.8 pounds and 16 inches in length. And just so you know, that size of a baby would be more consistent with a 4 or 5 month baby, not an 8 month baby. Discussion with neighbors and family turns out that she was secluded, isolated, suffered from bipolar disorder, and just did not have the help, mental help, or prenatal care that she needed to still be here with us. Our solution, and there are many solutions. There is not just one solution, but in what I've been thinking about and spending time thinking about is looking at programming that combines high touch with high tech, meaning that the high touch part is working with community maternity healthcare workers so that women have an extra voice, someone who is with them through their prenatal care visits, someone who hopefully is with them through delivery and perhaps a few months after delivery, so that they're getting the care and the follow-up that they need. The high tech part of it is using software to help us develop a mobile app that focuses on some behavior changes, anger management, life skills, and self-efficacy to help improve outcomes. I believe it's time that we start looking at innovative solutions led by medical experts to tackle the problem before it worsens. I want to spend just a few minutes on also just advocating for the fact that while programs like this may not be widely available, what is widely available is that if you know that you have a sister, a granddaughter, a niece that is currently pregnant or going through any health issues, I ask each and every one in the audience to go with their loved one to the doctor. I feel that family and friends showing up in the room, and if you can't show up in the room, then have them FaceTime you. I think that would add a certain level of at least having two people hearing what the doctor is saying or whoever the provider is, and having two people that are available to ask questions. But I really do feel like another level of the way we need to show up for each other is in a sisterhood type of fashion where we are helping each other with our doctor's visits and reminding each other to go to the doctor and helping with transportation. It really is getting back to the basics of community, and sisterhood is one of the key foundational components of where I think we need to start focusing on saving lives. So that ends my comments. I thank you so much for having me. I hope I didn't rush too fast through it, and I hope that, I left time for questions.
Thank you so much. That was so informative. And I think you gave us some great strategies for being good caregivers to our people. So does anyone in the audience have questions?
Oh gosh, I forgot my question, so I'll think about it.
What programs have we implemented thus far that are helping to improve these mortality rates for our Black women that are already in place that have a track record of improvement?
So there's some stuff that's on the hospital level that are called bundles. I find, and I tell this story often. My son played the trumpet. He had an opportunity to go to All State. The way they audition you for All State is that they have you step behind a red curtain, and then the three people on the outside, they know nothing about you besides a number. You're number 14. They ask you to play these scales, the chromatic scales, different things that you may have prepared, and then they listen critically. They do not know your race. They do not know your sex. They do not know your name. They do not know anything about you. They are there purely to listen. That is the way I think that, unfortunately, we can't blind someone in that situation, but what we can do is create standards. So now there are certain standards, but believe it or not, hospitals still have the option to opt out of those standards. So it's important that we start looking at our community hospitals and asking them, are they holding up ACOG standards? Are they holding up the standards for equity within healthcare? So one of the things that, can happen, one of the largest ways that we lose women is through postpartum hemorrhage, like we talked about with Kira in this presentation. Now what we do, or what's recommended, is basically every 15 minutes for the first 2 to 3 hours after delivery, whether it be a vaginal delivery or a C-section, the nurses come in, they strip back your bedcloth so that they can see. Because I actually had one patient who almost bled to death because the nurses just came in, checked, looked at her. She said she was fine, and they never pulled back the sheets, and she was in a pool of blood. And she didn't completely feel it because she had an epidural, so her sensations were off. So now, for hospitals that adopt these guidelines, there's a certain level of time that the nurses have to track how many times they've gone into the room. They're getting graded on it. The hospital gets graded on it. So there are certain protocols and bundles that hospitals are moving towards that make care like a recipe. So it's a standardization. So it doesn't have to be like, well, I think I'll go and check on Miss Johnson. No, it's every 15 minutes after delivery, you have to go in, press on her fundus, take her vital signs, peel back the bedding, and look and make sure to assess her bleeding. So there are bundles, the hospital bundles. I feel that those are working. And there are certainly, there's a lot of programs that are out there. Let me think of, so there certainly, much of what I'm saying, doulas can certainly, they've been shown to decrease morbidity and mortality. And again, that's along the lines of having someone that has your back. Doulas are not all created equal and come from many different backgrounds. Like some doulas are just, there for delivery. And, if you're going to deliver in a hospital, working with doulas also means getting everyone on the same page, getting doctors comfortable with your support person, your doula, or your maternity health worker. But definitely doulas have shown that they can decrease maternal morbidity and mortality.
Thank you so much. Another question?
My concern is with the rise of anti-abortion regulations. We are already having very high levels of maternal death, and now we have to wait till a woman is absolutely at the death's door to even do abortion care. How do you feel this is going to affect our numbers later? We can already see in Republican-led states, they do have higher levels of illness than Democratic-led states. Like, this should not be state by state, it should be federal to say everyone can be safe. But I will let you respond.
Yeah, no, that's the problem, is that the abortion rights people, they get really stuck on abortion and they don't realize that Planned Parenthood does so much more than abortion. They do women's health care. Planned Parenthood was the first place that I went to get started on the birth control pill. So they do so much more than that. And so shutting down these Planned Parenthood, shutting down these access points for women we've already seen it. Texas has been very slow to release mortality data because it is climbing up. Texas has a really bad problem because they're losing OBGYNs in droves. I literally get an offer at least once a week to come to work in Texas. I would never do it because who wants to be threatened with the thought of prosecution and jail time just for practicing your livelihood. I am a board certified OBGYN, and my job is to help people make their decision, to give them as much information as possible, and then let them help them with the information and to help them make a decision, knowing the information. And so in Texas, I wouldn't even be able to talk about abortion as an option. If I spoke about abortion as an option, I could be arrested, thrown in jail, fined, etc. So not many people want to work under those situations. And so they're losing caregivers regularly. And without the caregivers, there less and less places for women's health. So yes, I would like to see certain standards set in America, but it's hard to set those standards when we have those issues around states' rights. And yes, the states that have the most aggressive anti-abortion laws also have some of the highest mortality rates, because I actually had to look and see for Crystal Anderson if the reason she became septic was because she was in a state that didn't allow termination, because as you know, it was clear that this was definitely a desired pregnancy between her and her husband. But, you know, in certain states, if the baby still has a heartbeat, they would, even though there was no growth or no fluid around the baby, they still would not be able to do any type of termination because of a heartbeat. And so those are the issues. So is the question, do the states who have the strongest anti-abortion laws have higher higher morbidity rates? The answer is yes, definitely.
So Dr. Abdul Mbaki, thank you so much.
One more question.
I'm sorry. One more question?
One more question.
Okay, one more question. Go for it.
Okay, so good evening, doctor, and thank you for joining us. I got one question. So states like Delaware are moving forward with a lot of legislation around Black maternal health care. The policies are coming, the implementation is happening, not fast enough, but it's happening. But what do we do to combat the empathy that Black women have and receive when they're receiving health care in America? And you can expand that out or keep it to Black maternal health care. But from what I hear, from what I've seen, even experienced, that many medical practitioners ignore just the concerns, the words of Black women when they're being treated in medical facilities.
It's true, you know, you got to state it and realize that it's true that it happens. Serena herself said her voice was not heard. And so one of the things, like, that's the reason why I'm more pushing the community maternity health worker that has the training and making them a part of the medical team. There's a lot of sentiment around, you know, the hospitals are trying to kill us. We're going to do home births. We're going to just deal with midwives and doulas. That is fine for a subset of people. And when I say a subset of people, I'm talking about healthy women. And healthy means a healthy weight range. It means no other outstanding conditions like high blood pressure, diabetes. It means younger age, because as soon as you hit above 35, you are considered advanced maternal age. That makes you a higher risk. So there is a small group of women where the home birth and everything might be able to be an option. I don't want that to be where we head. I don't want the reverse to happen, where we now kind of because we feel like the hospitals are killing us, we move ourselves to homes, because that's going to be a worse situation, because everyone cannot have a safe home birth. Everyone, I'm right here. I'll tell you, I had pain relief. I had an epidural with all three of my boys. I'll also tell you that I had 2 vaginal deliveries. My first 2 children were by vaginal delivery. So by the odds, my third one should have been a vaginal delivery. That's not how Gabriel wanted to enter the world. He came with his cord hanging down first. That would have been a medical emergency. If I had tried to do a home birth, if I had tried to do a delivery with a midwife, any of those things would have injured my last child, may have even killed him, may have even killed me. In that situation, with the cord hanging down first, what I needed was an emergency section, and that's what I got. My very well-trained doctor got my baby out in 2 minutes, and he's beautiful, he's 10 years old, and he's as smart as anything. So what I don't like that I'm seeing develop is this animosity between doctors and doulas and midwives. It's not either or, it's and. to me. It needs to be collaboration, because there are patients for which a midwife is perfectly suited to care for and will have a great outcome. Those are lower risk patients. Unfortunately, a lot of African American women are higher risk patients for all of the reasons that I just detailed, because of the comorbidities of diabetes, obesity, hypertension, etc. And so, to answer your question, so do I feel like there is racism and problems with getting access and problems with being heard as a Black woman in the healthcare field? Yes, there is. How do I think you go about solving that? I think one of the ways is working collaboratively with a person who is part of the medical team, so that if we have these trained community health workers, making them a part of the medical team, perhaps even having them embedded in physician offices, so that when they say something, to say, Jennifer isn't doing like she usually does, or her blood pressures are higher. Now you have someone who has a direct contact and has direct access to the medical team. And so I think it's more collaboration, more voices. That's how we get to making things better. But it is a real problem. And so that's the reason why I said, if you have a young person in your life that you can approach and say, hey, you know what? I see that you're pregnant and I really want the best for you and your child. Can I go with you to your next visit, just so it's two of us listening and making sure? And so, not to be in a nosy way, but to be completely in a caring way. That's what I'm talking about as reinvigorating sisterhood, that we care about each other in that way, that we can take some time away and go to doctor's visits. Tom Joyner used to bring a loved one to the doctor, and that's more of what I think we need with these visits, especially the prenatal visits, where you're really taking care of two people at the same time. We need to have another voice there.
Thank you so much for an excellent presentation. We appreciate you. This was really great.
Thank you for having me.
Thank you. Now I'd like to introduce Mrs. Vicki Benson, who will introduce our guest panelists for the evening.
Hello all.
Good evening, everyone. I'm Vicki Benson. I will be one of the moderators for tonight's panel discussion. I've worked in the field of maternal child health for more than 25 years as a labor and delivery nurse, an educator, and a leader. And one of my most important roles is as a mother of two African-American daughters who themselves may be pregnant or have children. I am also a proud member of Zeta Phi Beta Sorority Incorporated, Epsilon Rho Zeta chapter. Our panelists tonight include healthcare professionals, educators, legislators, and community leaders. Their initiatives, policies, and programs advocate efforts on raising awareness and leading the fight to address and eliminate healthcare disparities in Black maternal health. Our committee organizers have pre-selected questions to facilitate tonight's discussion. Our panelists will share their knowledge, experience, and expertise on the subject matter. And without further ado, let me introduce our panelists. First, we have Ms. Mona Lisa Hamlin. And you can all come up and take a seat. Ms. Hamlin is a nurse manager of perinatal resources and community programs and the milk bank at the Women and Children's Services building at Christiana Care Health System. And unfortunately, we were supposed to have State Representative Melissa Minor Brown, who's a member of the Delaware House of Representatives, but unfortunately she got held up in session. So she is still working. So I don't believe she will make it this evening. She is also a registered nurse, a doula, and on the task force of social determinants of health. She's a community leader with the Delaware Healthy Mother and Infant Consortium. So hopefully if she is able to make it, we'll just kind of slide her right on in. We also have Ms. Cynthia Guy. Ms. Guy is a licensed professional counselor, a licensed master of social work. She's a women's health behavioral health consultant at Christiana Care Center for Women's Emotional Wellness. We have Mr. Joel Austin. Mr. Austin is the president and CEO of Daddy University, Incorporated. And I'm sure he'll enlighten us and tell us a little bit more about your organization. We have Ms. Michelle Johnson. Ms. Johnson is with Black Mothers in Power. She's the center director, and we're excited to hear a little bit more about Black Mothers in Power. And we have Dr. Amanda Watson. Dr. Watson is an assistant professor here at the University of Delaware, the School of Nursing, and she's a certified nurse midwife. So we will begin our panel discussion. We will have questions that we'll put out to the panel, and whomever is prepared to answer that question, we will do so. Please remember to allow an opportunity for all of those who would like to answer the question time, but still keeping it brief enough where you can make your point. Remember that we have to talk slowly and clearly for our ASL interpreter here. All right, so let's begin. First question. How would you suggest exploring the impact of environmental and occupational exposures on maternal morbidity and mortality?
Hello. Guess I'll go first. When you think of environmental, sometimes you're triggered to think of low income. You think of low-income housing, so you think of exposures to lead, to mold. And I'm proud to say that actually I was in partnership with my private practice, CLG True Solutions, with Delaware, Healthy Homes, with the lead prevention, where they actually would go out and do screenings, investigations for lead, and help parents with children up to age 6 that may be exposed to lead. So we do have different programs going on, boots on the ground, to deal with environmental factors. When I hear occupational, I think social economic, but just as we just heard, we have Serena Williams, where we know environmental is not a problem. We know occupation is not a problem. So therefore, it's something bigger and deeper that we're missing. And our Black women are still dying at alarming rates. So we think of these things such as access to health care. We think of these things as lead and mold. We think of these things as low income. But we also have to look on a broader scale on what are we doing with the women getting accessible to the healthcare, getting the support, things of that nature.
Okay, so I live in Sussex County, and that is where I mostly practice. My prior experience was working as a director of the Women's Health Department at a federally qualified health center in Sussex County, and so a lot of my patients were recently immigrated from Central and South America and Haiti. And so the reason that there's such a large immigration pattern into southern Delaware is because there are farms, and there's also a lot of chicken plants. So if anybody's familiar with Purdue or Mount Ayr, those are the two chicken plants in southern Delaware. So I also saw a lot of birth defects, very commonplace in the women that I was caring for. And I know that there was other risk factors involved, but I couldn't rule out the fact that they're working in these chicken plants, and not only are they being exposed to different chemicals, but they're also being exposed to different zoonotic diseases, so like diseases that animals can carry. And so I can't totally rule that out as having an impact. And then also just the working conditions in general were not always the safest. And a lot of women were sometimes working under alternative names or identities because of immigration status. So it limited their access to health insurance or family leave because they couldn't use their name that they were actually using to seek health care to file for those things within their workforce environment. So that's, the way that I think I've seen it playing out.
I'm Joel Austin. I'm also a certified postpartum doula. I founded a program called Doulas for Dads, and at this point we have 8 more Black male postpartum doulas. I've been in fatherhood for 20 years. One of the issues I see around this also is trauma. It is just cultural trauma, traumas from other things, conversations, and with the men that I serve, our focus has never been women per se, but it's been my wife, my baby mother, my situation, or situationship, and the care for them, and what information that they have received traumatically that kind of changes and pushes her in different areas. Our issue that we had to resolve is the education for them. They believe some things, and some things are not incorrect. They believe, specifically culturally, that she is eating for 2 and sometimes for 3 and sometimes for 4, and they had no knowledge of obesity and pregnancy. They believe in some of these things that we should be pushing on her, but a lot of them is trauma. They believe the doctor may do this, a doctor may do that, because there are times men aren't even allowed in an OBGYN visit, which is kind of strange because that's how babies get born. Kind of seen it already. Doc. And so some of these uncomfortabilities, or I walk in, I'm 6'2", 6'3", one of the things that you ask my wife is, are you safe? Mm-hmm. Are you safe to go with him? Are you safe? And I'm okay with that question. I'm okay with that question. If she says no, she's not, we have policies and procedures to protect her. We have resources. There's a clinician somewhere by, there's a social service person somewhere by to come out. We have things that we put in place to protect her, and she should be. Our issue is, if she says, yes, I'm safe, there's nothing. There should be some banners and some confetti that comes out saying, you're a great dad, and you're one of us, and you're protecting her, and you're safe. Let me give you information. Let me tell you about her blood type. You're allowed now, for the first time in your life, to ask her weight. Just for 9 months, don't push it. Don't push it, just. You're now, when did you go to the bathroom? How much sleep did you get? Some of these things are determinants. We deter them from doing these things, and traumatically, we're gonna have to go back to say, you're involved, you're included. I know before you that there was blood in the toilet because I wake up every day with her. And I need to be able to trust you and tell you something's going on, and I'm not sure. So, and I'm here because a Zeta asked me, and you don't tell Zetas no. I'm here.
I tend to answer these questions by telling stories. I'm a storyteller. And prior to coming to Black Mothers in Power, I worked as what we call a maternity navigator in Philadelphia. And some of my clients, they lived in the southern part of Philadelphia, and they migrated here. So I had one client who was seeking asylum, and she had high blood pressure. She had high blood pressure in pregnancy. And I would tell her, you know, we need you to do this, we need you to do that. I need you to go to the doctor. I need you to record your blood pressure. And one of the barriers to having her get care and get it on time and have quality care was that she did not have insurance. And so every time I told her, hey, let's go, can I go to the doctor with you? Or what did your doctor say? She would make up stories about what her doctor said. And it wasn't until we had to rush her to the hospital because her blood pressure was at an alarming rate that I found out that she had not been to the hospital. So I would consider that to be one of those barriers that we face in different populations. And in that work, one of the questions that recently came up is, why aren't we, there's a large population of these people in this area of Philadelphia, why aren't we helping them in larger numbers? And I'm like, well, we don't have the capacity. We don't have, you know, French-speaking medical professionals in large numbers to touch them, or who are able to do it on a community level. So yes, that has definitely been a barrier in this work.
Thank you.
Okay. Hi, everyone. I'm Mona Lisa Hamlin, and I'm a nurse and really do a lot of these talks. And I would bet you that tonight, one of the topics that Representative Minor Brown is talking about is paid family leave. When we think about the parents that we are trying to care for, we need to also consider the work conditions that they're in, right? Are they able to leave their place of work with enough time to be paid for the time that they're missing to go and get their prenatal visits? Are they expected to return back to work within a couple of weeks? I actually have a patient right now in our queue who is actually going to have a loss as predicted by fetal diagnosis after the birth. And she's worried about having to go back to work because her employer is less than 50 employers, and she's not covered under the Paid Family Leave Act. And so when we think about occupational hazards and things from that standpoint, and really what our resources and support looks like, that's one of the things that we certainly need to improve on.
Just an interesting point. In Pennsylvania, I am a strong advocate for maternal health, strong advocate for Black maternal health, and a strong advocate for paternal inclusion, because we still make babies the old-fashioned way. In Pennsylvania, more men than women work in union, and it might be the same in Delaware. It is highly interesting that in union, they get almost 6 weeks paid time. So more men have more paid time off with families. More husbands have more paid time off than the actual mother that's given birth. That has to change. On the other hand, the other thing that has to change is you have to have a class for them. If they have the ability to be home, if they have the ability to care for the infant, if they have the ability to do this, you have to have a class for them. There are almost no classes for infant care, specifically for husbands and men and new fathers, and we can't advocate and non-advocate at the same time. That'd be asinine.
Thank you. How can we best address these issues in higher education to future healthcare providers aware of these racial disparities when treating patients? I'm looking at my educator down at the end.
I feel like I'm being looked at for this one. So I just joined the School of Nursing, and one of the courses that I teach is women's health across the lifespan. And I realized that my nursing students are not all going to become labor and delivery nurses or postpartum nurses. But one of the most important things for all of my nursing students to understand, one, blood pressure is what blood pressure is, no matter what is stressing you out. And we have to believe that, and we need to rapidly treat that. So that is a very important thing that I put like kind of drive into my students. But the other thing is that I really want to bring awareness to the fact that over 50% of the deaths that we see in this country happen after babies are born. And so if we're not aware of the fact that a woman just gave birth and she walks into her dentist's office, or she walks into her primary care office or an emergency room, and she has symptoms of preeclampsia, which can be life-threatening for her, if we don't understand that there's a major physiologic change that's happening to this woman's body that can last up to a year after she's given birth, then we can miss these severe conditions that can take her life. And we do have to remember that without these moms, and without healthy moms, because we have to include, you know, mental health in this as well, and the stability and the support, especially like fathers learning how to support moms and things like that too, that will affect the ability of the babies and the children to grow up in a healthy way as well. So we're not only protecting moms by doing that, but we're protecting young children and we're protecting families, and it, you know, it's a cyclical event. So I feel like we need to bring not only the women's awareness to that, but then also, you know, the disparities, and that it's not equal across the board, and that we really need to listen to women and listen to what they're telling us when they come in the door.
Thank you. I actually had an opportunity. It was one of those unfortunate opportunities that COVID brought forward around really putting hospitals in a sticky place where in the beginning we had no idea what was going on. And I'm sure everybody in this room remembers when birthing parents were separated from their support people, right? And they were also separated from their, not just their support person, but also their doula in many cases. And yet what we found was once things were starting to be a little bit more understood several months in, we were still having nursing students come in. And with that came the opportunity on my end to create something called a birth companion program. And this is actually after the Johns Hopkins model, where we took a group of nursing students. I have one in the crowd right now. And really, they voluntarily took a course, not for credit, but really for the experience. And it's all on the platform of leading with equity, really incorporating that empathy part of it and considering the whole person that we're serving in regards to being that birth parent, incorporating the partner, and really standing by their side when it comes to being able to ride through the rest of their pregnancy, really be prepared for the birth by way of understanding what that provider is saying, but also from the nursing student's lens, they're gaining an extra level of education on how to support a family. To your point, Dr. Watson, no matter what field they go into, right? Whether they go into oncology or OB, they'll be able to take that lens of really considering the whole person and taking a moment to listen and communicate back and really use motivational interviewing skills, for example, to ensure that there's rapport being built there. And we can do this at any level. It needs to happen at any level, right? From a nurse perspective at the bedside, I know we're a lot of checking the box. We've got a lot of things going on. Maybe we have a high volume and we've got a large patient ratio, but just taking a beat to listen really can take us far. It can really help us dig a little bit deeper as to what's going on with, you know, that birthing parent, that dyad as a whole, the infant, even the other partner in the room that is trying to sort out things and wants to be the fixer and really wants to know what's going on so that they can soothe the person that's actually receiving the care. And so I do think that I'd love to see this happen at every level. We do have our Momnibus policy for the nation, but also for Delaware. That includes training such as anti-bias training, and so I think that's a great start. There's a lot that needs to come along with that, but this really does need to happen for any type of clinician or supporter that's going to come in contact with that birthing family.
I just wanted to chime in. Can you still hear me? Yeah, I'm still here.
Yes, go ahead, doctor.
I work with medical students. They rotate through my practice. And for me, the empathy boils down to simply talking to them and telling them to treat the patients as they would someone in their own family, their father, their mother, their sister. That is how I practice medicine, is by feeling a connection to the people I work with, not as viewing them as the congestive heart failure patient in room 2, but knowing that their name is Mrs. Johnson, that she has 2 kids, and you know where she works. It doesn't, to me, I mean, to me, I don't think it takes that much. To me, I really, you know, I think and time again, we see that people are able to do some real atrocious things to other humans simply because they view them as other. And I think being able to learning how to view people as humans, as part of the same family, as really just treating them like they were your mother, your sister, your uncle, goes a long way to having empathy.
And real quick, a lot of us that are in birth work, there is one word, and for everybody up here, that we hate. It also drives us. It's this nasty word called preventable. It keeps you up at night. It is that relationship with the supports that somehow I am not sure the answer how to fix, but there is one person that's called a patient, and then there are supports. And we keep finding out supports are being told sometimes after grief, this could have been preventable. So now the supports are thinking, what nutrition did I do? What did I cook? I should have told you more in that intake. And I wish there was a Match.com for the doctor and the nurse, the patient, and the supports. Patients, my new mothers, they're not liars. They don't always tell the exact truth. They believe sometimes that cherry vanilla ice cream is a salad. It's not. The supports will tell you everything you need to know, everything she has done and everything on this list. The supports will make sure that list gets done. The supports will make sure she does go for that walk, and the supports are behind her the whole time. Our husbands and dads and partners and these supports and grandma will make sure she eats fish whenever you want her to and all the vegetables she wants. So there has to be some time when the patient and the supports and the hospital staff kind of come together for the cure. And the second one is just specifically around racial, is this attitude, this Black woman's attitude, this Black man's attitude. I have to tell you that I've had clients that have been asked to leave the hospital because of their attitude. They were loud. They're big like me, and they were upset, and they're angry, and anger for someone this color looks aggressive, and aggression looks like assault, and now I'm scared of him. Let me give you permission. It's really fear. Things are going on. You're not giving me an answer. I don't know what's going on and happening. You brought out this sword and stabbed her in the back. What's called an epidural, same thing. She's now screaming, you haven't adjusted me. I didn't even know what was going on. I've never heard of this word epidural because I promise you in the barbershop, it never comes up. And this thing about Black women's attitude, and some of it is shame. So learn to address fear, learn to address shame, learn to address these deep down emotions, and forget all the tones and all of that. It's just fear. I swear, if it was allowed, I would write into the policy that you need to start hugging people for no damn reason whatsoever, specifically in labor delivery. You should just walk up to anyone in labor delivery that you see, because everyone in labor delivery needs a hug.
That's very good. Thank you. Ms. Guy?
And one last point, and I promise I'm not here to psychoanalyze everybody, but we should always ask why. If you're in the healthcare profession, always ask yourself why. Remind yourself why you're doing this work, and most importantly, read the chart. I work in a lot of women's health offices, and I've experienced a nurse go get a mom out of the waiting room. It says, "Oh, how's the baby doing?" Baby has passed. Please read the chart. Know the patient before you call them back. Small talk sometimes is not the way. Know your patient.
Absolutely. Thank you for that. Tonight, I've heard several examples of women who've experienced hypertension in pregnancy. I was one of those women who had severe preeclampsia in 2 pregnancies. With the recent first FDA-approved blood test that predicts preeclampsia, what are your thoughts on how much of an impact this will have on not just Black mothers in the United States, but globally?
I will take this. I think risk screening is incredibly important. And I think that early intervention when we are identifying risks is also very important. But I think we also, as healthcare providers, need to think about how we are discussing these risk factors with our patients and our support people, and how they understand what these things really mean. Because I think we, to bridge off the last question too, like we need to teach health literacy and we need to teach equity. And equity doesn't always mean giving everyone the same information. It means giving people what they need to be on the same playing field. And so some people might have a language barrier, or some people might have a difficulty understanding what they're actually looking for, or what a risk factor means for themselves or for their partner or for their child. And so giving patients the tools to be able to recognize that for themselves and help to be part of their own care management. So that, because they are, for a pregnant mom, the first person that's gonna know something is wrong with her child is that mom. And the first person that's gonna know something is wrong with their partner is the partner. And so if we don't give people the tools that they need in the language and the format that they understand, to be able to identify those risk factors and know how and when to report them or where to show up to when they occur, then it doesn't matter what kind of screening we do, we're still gonna have the same results.
Yeah, and I would add to that, standardization of care is great, right? I heard the bundles mentioned earlier, and to Dr. Watson's point, we're thinking about how do we always care for folks the same way. But if we continue to have obstetric racism within our systems, then no matter how some of our patients are presenting in front of some of our providers, especially those who don't resonate with equity training and anti-bias training and the clear data that is within our nation, then that standardization may still be missed for that patient who needs it. And so I think we can't have the standardization without the equity piece. And that is something that I would love to see from the bundles and other recommendations that are coming out of leading health organizations, to make sure that when we're talking about obstetric care, that we're truly weaving in how to do it with an equitable approach at all angles and at all policy levels.
Thank you. So speaking of giving tools and strategies that our patients can use, what strategies have you implemented in your clinical practices to address racial disparities? What is working well, and where are your areas of opportunity?
I'll take this one. So at Black Mothers in Power, we train doulas, and we have different cohorts. Right now we're on our 4th cohort, and they have different programs that they go into after they complete their training. So one of those programs is our domestic violence program, where people with lived experience are training and walking them through to certification. Another is our substance abuse. And so, again, storytelling. Someone came into our center and she was asking about feeding. Her baby is about 3 months old, and she shared that she was told, because she previously was using illegal substances, that she could not breastfeed. And so I asked her what her source was, and she told me, I don't even remember what she said, but it didn't sound like a reliable source. And I just instantly thought, if we were able to connect her to a doula who was skilled, one of our doulas who were skilled in substance abuse, they could have made the right references. They could have walked her through pregnancy, through postpartum, and answered any questions that she may have had that were more focused. And I think that if we had some more programs like us around, we could reach far and wide to people like her who need it. Because I instantly thought, I was fortunate enough to breastfeed for about 1.5 years. Would not recommend. It wasn't fun. But I did breastfeed my child, and the look on her face when she told me that she was not able to, and we were talking about formula options, she really looked devastated, and I couldn't imagine being a mom and not knowing the best options for my child, or being told that, hey, you can't breastfeed because of a choice that you made and you were trying to recover. So I started talking and I forgot what the question is, but I'm pretty sure I answered the question. You did. Okay, effective intervention, yes, thank you.
So we are doulas for dads. We only work with couples. We are fortunate enough to be bilingual. I am a lingual in paternal inclusion, paternal health and health wellness. I'm bilingual in maternal inclusion and wellness. I understand fathers go through postpartum depression as well. We make them what we call our first responders. But my first time sitting with a couple is I talk to mom, and I'll ask him, can I talk to mom for 5 minutes alone? And we have those honest conversations. But I also have a private conversation with my partners and dads. And I say, in maternal health, there is a chance, if you don't help, in maternal health, there's a chance that mom may not come out. I also say to him that in Black maternal health, there's a chance that your mother and your new baby may not come out. So let's have this straight up, forward, honest conversation. Because my dads are put in charge of the pregnancy. I know that's kind of weird, right? They are put in charge of the pregnancy. What we're not going to do is make a baby and play Xbox. Like, seriously? Allowing them to take a back seat is not something we're doing anymore with these numbers. They are in charge of getting her to her visits. If you're working, that's fine. There's this thing called Uber and Lyft. They are in charge of it to make sure she gets there, because sometimes mothers just don't want to go. They are in charge of nutrition. Yes, preeclampsia is brought on by sodium as well. And yes, pregnant women are very scary. If they say they want McDonald's, they want McDonald's. They're scary, y'all. I don't care what their size they are. but you're in charge of nutrition. You can have a salad delivered. You can still get the burger, but now you have to get some apple slices. You just can't keep doing the French fries. You can't keep frying everything. You buy an air fryer. Like, you have to make sure certain things are done. Transportation, nutrition. I don't care if you're in a food desert. Call your brother's cousin's nephew, and you know a guy that knows a guy that can get her some vegetables. Like, you have to be in charge of this. You have to be in charge. You can't even come home and take your clothes off until you walk her around the block, until you ask her how things have been. And you're in charge of skin to skin, and you're in charge of chest feeding, because the best gift for a new mom is this thing called a nap. And if you get her a nap, they're all the best size. You don't have to worry about whether they fit. The longer she gets one, the better, and be in charge of her sleep and everything like that. So it is pushing out these supports, pushing out these opportunities, and then pushing out these changes in this dynamic of maternal is not a single thing. It's a family, and there was a separation in our society. Fathers were not even allowed into labor and delivery until 1980. And those were married fathers until 1980. That was 44 years ago. Most of the guys you meet have a dad that has a dad that brags about not changing diapers. And that's not the way it is now, so some of them don't know. One of the issues that when you look at a gynecologist's office, it's a women's room. And I'm taught not to go into a women's bathroom. So we sit outside in the parking lot, but one day, magic happens, and now it's an OBGYN office, but it looks the same. So it has to be more inviting, and you have to change it, and you have to look and say, why aren't they coming to these visits? Because it's a women's room. And you have to be the ones to invite them in and say, no, 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 please come on into this visit. Please come in and take notes, because I'm a little busy right now. Most mothers that I come across, all they're thinking about in the visit is, I hope I don't sneeze, because if I sneeze, it might come out 2 or 3 different ways. Don't even, so I have my dads taking notes. I have them doing this. They understand football, so they can understand different colorizations. They understand different weights. They understand what you're supposed to eat and where she's at. So the involvement is our new way and our new opportunity of making change in this maternal health.
Shout out to our doulas. Shout out to our midwives. I mean, right, the statistics are so positive in regards to reducing those disparities, decreasing cesarean births, and improving outcomes overall, starting breastfeeding. But we can't do it, and we can't depend, I should say, just on them. Right? One of the things we had, it's Black Maternal Health Week. Actually, this is the day after, right? I love that the conversation is continuing on, because it can't just be stuck in a week. But one of the things that we talked about at the DHMIC conference yesterday was really ensuring that there is transparency in the information that's happening within healthcare, because that's going to fuel the consumer to really give input as to what they want and need. At Christiana Care, we are hosting sharing circles, and we've partnered with our local community doulas to really help get the word out. And we're looking for Black birthing people who have delivered within the past 12 months to really give us their open and honest, in a safely created space. And hopefully there's some trust in those spaces that we are gaining a good amount of feedback, because we want to know what's next. Where do we need to start? Right? We talk a lot, Vicki and I talk a lot about opportunities in the home after discharge. You know, health systems, when we think we've got it right, we're like, okay, you're good during the inpatient stay, but what happens after discharge? That's right. We've got a lot of things on the horizon, but one, who's at the table in those conversations? Is it the folks that are actually receiving the services, been there, done that, and going to not just tell you, what worked well, but truly where we could have done better? And that really starts from the entry point, right? Oftentimes in the preconception period, before they're even thinking about birthing a baby, but certainly during their pregnancy, they want to understand what to expect with their own bodies and what to expect in the healthcare system and how to navigate that. And so it really is going to take receiving that feedback, taking those stories, pairing it with the data, and then making moves accordingly and holding ourselves accountable back to the consumer, back to the community, to show that we're walking the walk and not just talking it.
So speaking of transparency, I cannot let this question pass by without speaking to something that's happening in Sussex County. Sussex County has 3 area hospitals, and there's about 2,200 women that deliver down in Sussex County every year. About a third of those women seek care from a federally qualified health center, and about 80% of them don't have access to Medicaid while they're pregnant because of their immigration status. So that means that they get Medicaid to cover their delivery, but all that time that they're pregnant, all of their labs, all of their ultrasounds, all of their visits with the high-risk perinatologists, all of the consults for the, the extra heartbeat that we heard while we were listening to the mom, the nephrology and the endocrinology consults, all of that, none of it's paid for. It all has to be paid out of pocket. So, and you're talking about a patient population that one visit might cost them somewhere between $800 to $1,200 to go see that high-risk doctor that they really need to manage their health. And that might be an entire month's income for these families. And so what happens is they just won't go. So we were talking about asking people why and like listening to them, like what is the barrier, what is happening? So what we did as a response, well, back it up just a little bit. Let me just say one more piece of this too, because we're being transparent. There was actually about 6 months in 2022 where not only did these patients not have access because of their insurance, but they were actually systematically excluded from access to a certain hospital because of where they got their care. So that hospital was like 3 minutes down the street from them. And they were continuously told, you can't come here because that contract is over. You don't belong here. You're not supposed to be here. And so we had to find solutions to be able to create access where there was these huge walls and these huge barriers. So one of the things that actually ended up being pretty helpful for that patient population, and this might help in the Philly area that you were talking about, is a lot of these hospitals had financial assistance programs. So they give, for people that are self-pay, they give them discounts, or if they are under a certain federal poverty guideline, they'll cover their care 100%. But these applications require pay stubs, bank statements, W-2 forms, things that these patients didn't have to produce. But we had different ways of verifying their income at the federally qualified health center that we put them on a sliding fee scale. It could be a handwritten income statement from someone that was paying them cash under the table or whatever it was, but it gave us an idea of what the household was making. So we made an agreement with the hospital system that we would just produce a form, a one-page form saying, this is how much money this family makes, this is where they fall on the federal poverty guidelines, and we are verifying that income. And we fax it directly to the financial center at the hospital, and it would automatically enroll them in financial assistance. So now those high-risk perinatology visits that are $800 a piece are covered 100% because we bypassed this barrier of this application process that our patients couldn't navigate and couldn't manage. And so we need to be creative. We need to be really innovative in how we're thinking about the solutions. And we don't know what we need to do to innovate until we really talk to our patients and figure out, like, what is really the problem here? How come you didn't pick up your medication from the pharmacy? I ordered you an antibiotic for your UTI. How come you didn't pick it up? Well, I went to the pharmacy, I looked for it on the shelf, and I couldn't find it, so I left. That, to me, was like an aha moment as a provider. I'm like, oh, I have to remind this patient that this is a prescription. They need to go to the back of the pharmacy where the window is and pick it up there with an ID. And so, but that, you know, if we're not asking why, then we don't know how to fix the problem. So, root cause analysis.
Thank you. This is a great discussion. I'm gonna let you make one last point because I'm tasked with keeping us on time.
So my point is short. I call my lady patients my butterflies. So as my young butterflies would say, I have to keep the same energy, which means who you see is what you get from the beginning to the end. I have to be consistent, I have to be reliable, I have to be trustworthy, and I have to listen. And most importantly, continuously always being a part of my community. Please stay a part of the community, include the community, and you will always win.
It's wonderful. I just want to thank you all for joining us. I'm calling all the Fab Five. This was such an engaging conversation tonight, and truly appreciate you taking time on a Thursday to come out and spend with us. And I hope that everyone had a great time and enjoyed our presentation tonight. We have one last thing. Alicia Downer will be coming up. She will be introducing our Madam State Director.
Good evening. Thank you very much for coming this evening. My name is Alicia Downer. I am the Facilities Coordinator for the College of Health Sciences. I am also a member of Epsilon Rho Zeta chapter. I would like to take a moment to introduce our State Director, Shanina Davenport-Fogan.
Good evening, everyone. Good evening, everyone. So as she said, my name is Shanina Davenport-Fogan. I am the Delaware State Director, full transparency from the beginning. I was asked to speak tonight and I said, I can't. I got a work obligation. I can't. This is not my level of expertise. But just as Mr. Austin said, you can't say no to a Zeta. I should have known that. But tonight has been extremely insightful. Thank you so much for this engaging conversation. Thank you to our doctor. Oh, she left us for her presentation. So I'm going to just get right into it because they only gave me a short period of time and we're already a little bit behind schedule. So I told them, what am I supposed to talk about? What am I supposed to talk about, Alicia? So she said, just talk about some of Zeta's initiatives. How are we engaging our communities? How are we bringing awareness to the communities? And hopefully after tonight, we'll actually gain some additional partners. So for the sake of time, I am going to stick closely to my notes so I don't forget anything, and I will do you justice, Sir Alicia. So just let me begin by sharing one of Zeta's signature programs is Z-Hope, and that stands for Zeta's Helping Other People Excel. And one of the ways that we can do that is having forums such as we're having this evening to educate, to bring awareness, and to provide resources on topics that are extremely important, but it's not profiled on high-level platforms. And I will say tonight, this is an extremely important conversation, and I believe this is a high-level platform just from you being here, so we thank you for that. Just not here in Delaware, but Zeta's nationwide, we advocate to eliminate racial disparities in maternal and infant mortality rates on behalf of Black women. So we feel this is important to our communities that we serve and have committed to continuing to advocate for this important cause. So our doctor, the keynote speaker, as well as our panelists, gave us a lot of facts about Black women who have the highest infant mortality rate in Delaware. So I will say that Delaware is making strides to reduce maternal mortality rates with the passing of 6 maternal and infant health-related bills into law. However, the disparity, just like the panelists talked about, the gaps are widening due to structural racism, implicit bias, and its subsequent impact on care rendered and health disparities. Members of my sorority, Zeta Phi Beta Sorority Incorporated, worldwide are shining a light, not just during Black Maternal Health Week, but we try to do it on a daily basis. And this is a cooperative project that we do with the March of Dimes. And I'm proud to say that we have been in partnership with the March of Dimes for over 50 years. And one of the things that we have worked on is the Stork's Nest. I don't know if many of you are familiar with the Stork's Nest. Raise your hand if you're familiar with the Stork's Nest. All right, and our goal, that's not a lot of hands. Did I miss a couple? So the goal of the Stork's Nest is to increase the number of women receiving early and regular prenatal care in efforts to prevent cases of low birth weight, premature births, and infant deaths. So I will tell you, being a mother of a son who was born 2 pounds, 2 ounces, and 14 and a half weeks too early, our programming is extremely important to our community. So I am grateful for what we are doing in the community. Zeta currently in the state of Delaware has 3 Stork's Nests, one in Newcastle, one in Sussex County, as well as one in Kent County. One of the things when we're talking about this subject tonight that I'm extremely proud of is last year, Zeta's was able to bring awareness to the legislators, and we received a tribute from Senators Nicole Poore, Kyle Gay, and Trey Parody for bringing awareness through our actions on racial disparities in maternal and infant mortality and the profound impact it has on our families here in the state of Delaware. So I don't know if you're familiar, because I'm from Philly, so I don't know all of these bridges, but if you cross the Charles W. Cullen Bridge, or was in Kent County at Legislative Hall last year in November, we actually was able to turn both the bridge as well as the hall purple in November for awareness of Prematurity World's Day. So we are trying to bring awareness in innovative ways, just to also talk about the importance of proper health care as well as just access to healthcare. That's something I think that we could talk a little bit more about. So earlier I mentioned, I'm looking at my time, trying not to rush, but earlier I mentioned our signature program, Z-Hope, Zeta's Helping Other People Excel, which is a combination of holistic and interactive outreach programs, and it's designed to enhance, cultivate, and empower our participants to develop health-promoting life choices across the lifespan. And our target population are women, children, men, we don't want to leave the men out, our seniors, and international women of color. So with our programming, we focus on socializing the concept by leveraging initiatives of our partners for greater impact and supporting the causes that aligns with Zeta's service profile. So in addition, and this is what Alicia really wanted me to talk about, but I had to give you the backstory to get to the current story. And so in addition to our Z-Hope program, our international president has charged each member this year to focus on the power of she. And the power of she is, or the acronym for she, is social justice, health justice, and economic justice. So this is why it's so important that we are having this discussion tonight. So and I'll be quick with the S and the H and the E, but our social justice is our political and philosophical theory in action that focuses on the concept of fairness and equal access to wealth, opportunities, and social privileges through social action, political and social service initiatives, and partnerships. So you will hear me repeat the word relationships several times, and that's because we truly are stronger together. We truly can make a greater impact in our communities when we are establishing and sustaining partners within our community. So having said that, one of the things I like to contribute our success is through our social action committee, and they have built relationships with our legislators, with our senators, with Bethany Long Hall, who comes and supports all of the events hosted by Zeta. And we were able for 3 years, this would have been our 4th year, but we're going to wait until next month. We've been able to host Blue and White Advocacy Days. And what that is we have a seat at the table. We're actually creating an environment to engage in conversations and make a difference. And one of our sponsors, Senator Gay, we partner with her on a car seat clinic where we were able to, and we did this statewide, where we were able to meet with families and actually educate them on how to properly secure their child in a car seat. And you would be surprised that 4 out of 5 of the families were not securing their child properly. So it gave us an opportunity to go back to Senator Gay and say, hey, we need to do something else about it. So if you look up Bill 68, from our work, we were able to get that passed. So I'm not tooting our horn, but I am tooting my horn for Zeta Phi Beta Sorority Incorporated, because it just shows you through relationships the power of support, the power of partnerships, the power of education, the power of our panelists tonight just educating us on topics that are not often talked about. So let's get to the H, and the H is for our health justice. And the health justice is just a part of our programmatic focus that seeks to recognize and build the power of individuals and communities affected by health inequities to create and sustain conditions that support health and justice. And then our economic justice is to create opportunities for all to succeed regardless of your sex, race, age, ethnicity, your religious background. And again, partnerships are vital. So we were the first D9 organization, so I'll say it again, Zeta Phi Beta Sorority Incorporated, to partner with D-Free. Has anyone heard of D-Free? No? Okay, so I'm giving you education. Look it up because we're talking about partnerships. So D-Free is a global foundation, which is a nonprofit organization, and their charge is to work with African American communities to financial freedom. I don't know about you, but I want to be financially free. I want to be debt free. So that is their focus on working with our communities on financial freedom through content, curriculums, and training. You can look them up. They are free programs. So that was the S, social justice, H, health justice, and our economic justice. I do want to note our Get Engaged social action programs such as Get Out to Vote, that's why I have my vote pin on, domestic violence forums, and forums like today has mobilized the Zetas here in our state, and we're trying to find new ways to address old problems. We're trying to not actually have the solution, because we know it's going to take time to address these issues that are plaguing our communities that we serve. So again, thank you to my organization, Zeta, and all of the partners who have put on this program today. And I know that I said a lot in a short period of time, but if you don't remember anything that I said, please remember to create spaces. Please remember to create those spaces for dialogue with our legislators. Create and sustain relationships with our community partners. Jana, I can't even pronounce her name, but I stole her quote. Jana Cachola said, "No voice is too soft when that voice speaks for others." So thank you for your time and attention tonight.
Thank you, Mrs. Fogan, for that powerful call to action. My last role here is very short. So I want to acknowledge all of the great people who were responsible for this event being a success tonight, and it was an absolute success. So thank you all for coming out. I want to start by thanking our planning committee, Miss Alicia Downer. Alicia came to me last semester and said, "Hey, I had this idea, let's do it." And I was like, okay, let's do it. And it has been such a pleasure working with you. She is so organized, a taskmaster. Thank you, Alicia. I also want to thank Mrs. Vicki Benson and Aisha Monroe. There she goes over there. That fills out our planning team. Thank you. I chose another path, but for the last 4 months, I've been an honorary Zeta. Okay, I'd like to also thank the leadership and membership of Zeta Phi Beta Sorority Incorporated for their hard work, financial support. I want to especially acknowledge the undergraduates here in the sorority that supported us. Miss Ronica Adams, who designed the beautiful save the date and registration flyers. Thank you so much. I want to also thank the Faculty Senate CAPE Committee, who supported us with funding, as well as the College of Health Sciences. Nemi back there for his IT support tonight. Thanks, Nemi. University Media Services, the young man recording us tonight. Thank you so much. Ashley Larimore, our college photographer. Thank you, Ashley. And Maggie Lyman, our ASL interpreter tonight. Thank you, Maggie. I'm so sorry for blocking your path earlier. I was just fumbling around. Okay, thank you again all for being here, and please look forward to future events from us. This was really a success, so hopefully we can do it again. Thank you, and have a safe travel home.